Welcome to Caregiver Cast. I'm Mary Elaine Petrucci, your host. My guest today is Tina Baxter, who is a geriatric nurse practitioner and also a caregiver who will be talking to us about her experience as well caring for a family member as well as being a nurse practitioner for geriatric patients. So welcome, Tina. Welcome to Caregiver Cast. It's good to see you.
Thank you for having me.
Most definitely. I'm just going to read a little bit about your background and then we can get started. Tina Baxter is an advanced practice registered nurse and a board certified gerontological nurse practitioner through the American Nurse Credentialing Center, who resides in Anderson, Indiana. Mrs. Baxter has been a registered nurse for over 20 years and a nurse practitioner for 14. She's the owner of Baxter Professional Services, LLC, a consulting firm which provides legal nurse consulting services for attorneys in insurance professional, wellness and chronic disease management coaching, and customized educational and operational resources to healthcare organizations. She provides a weekly Facebook Live program on business and health topics. Ms. Baxter teaches stress management strategies for clients of all ages and offers virtual as well as online classes. She is listed as the best lessons for 2019 and 2020 for lessons.com. She's the founder of the Nurse Shark Academy, where she teaches nurses to launch and scale their businesses. She's a certified small business and benefit solution advisor with Legal Shield Business Solutions. She's a public speaker and has spoken on numerous topics on the national level. She is a contributor to articles on electronic and print media such as entrepreneur.com, The Minority Nurse, LinkedIn, as well as a guest on numerous podcasts. Welcome. Wow, quite a bio there, Tina. You've got a lot of information to share with us today. Let's start first with your caregiving experience and then move into your nurse practitioner expertise and then the advice that you provide for the legal profession. So
Okay.
what is your caregiving experience?
Well, I've had to, there's a lady at my church, through a variety of circumstances, her family could not be her power of attorney.
Mm.
And she was being railroaded. She was living in a group home and was pretty much being railroaded by the group home. So the church had asked me to intervene to help her because they had said that she was not able to go to church anymore because she was falling. So I was able to step in. We got an attorney to take her case and help draft her power of attorney and advance directives and all that stuff that we needed. And we were able to help get her placed into a nursing home. And so I've been taking care of her ever since. And so it's interesting to be on the other side because I was a person providing the care in the nursing home. And now I'm the family member in the nursing home and attending the care plan meetings and having those discussions. So that was a very interesting way of seeing the other side of the equation. And it helped me to understand a little bit more about what families experience as well.
Most definitely. What were some of those experiences that you saw in those team meetings that showed you what a family member needed to take a look at very carefully?
Well, what was interesting is when we were having the discussion about her advanced directives and wanting to know if she wanted to remain a full code, having that conversation with her and ask her if she understood what that meant. And so we really had to break it down to her and kind of, you remember when you saw in this movie and they were doing the CPR and they were pushing on their chest, and she's like, oh no, I don't want that. So we had to go through it very basically. And I wanted to make sure that I included her family in that conversation. I didn't want to be the one to just say, okay, that's what we're going to do. So we had her daughter on the phone, who was basically like, if that's what she wants, that's what she wants. So I was like, okay. But I wanted to make sure that they were there. And every quarter or every so often, we still revisit that. And it's interesting. You still have that conversation of, is this still what you want? And not having always been present in those care plan meetings, it's good that I know that they keep asking if that's what they still want, because they may change their minds, and that's fine. She's pretty much adamant that she doesn't want that. So.
Oh, that's great to hear that you were there advocating for her and with her daughter. So kudos to you for doing that. Are there particular things that a caregiver or a family member should look for when they're placing their loved one in a nursing home?
One of the things, I just wrote an article about this in my newsletter. One of the things I always tell people, visit the facility, see if you can, stay for lunch. Maybe talk to some of the other residents if they're willing. Take a look around, and then do read those surveys. They should be showing you those annual surveys that they have from the state. And if they have any complaints, it should be readily available. And then kind of look at how the staff treats the residents. Having been on both sides, I can definitely say the facility where she is, they love her there. They let her get away with stuff that I wouldn't let her get away with.
Of course.
So I have to be the heavy and say, stop with the pork rinds, okay? That's why your stomach hurts. But they really love her there, and they go above and beyond for her. Yeah.
Is that a kind of like a put on experience for for this church member? The reason why I'm asking that is, are they putting on a show while you're there, or is this something that they do, you can tell that they do all the time?
I can tell that they do all the time because, number one, she would call and tell me. But two, the way they talk about her and the fact that they encourage her, I can see it. I mean, they did things for her, like they helped rearrange her room for her. They helped if her refrigerator went out, so they found her refrigerator. These are things that, like I said, she's on Medicaid, so she doesn't have a lot of money. So sometimes the staff will go out of their own pocket and help buy her something that she wants.
Oh, that's really nice. That's very generous.
Yes. And so that's what I said. When she didn't have a lot of money for outings, because, I would give her some money, but she's not always the best steward of her money. They would kind of figure out a way for her to go on the outing. And they didn't have to do that. So, and like I said, her family cannot be supportive of her. And then when one of her daughters died, they were always very supportive, and they always call me when something's going on. So it's really nice.
It's good that you have that relationship, not only with that church member, but her family as well. Because I think that really makes the continuum of care much easier, and everybody knows what's going on all the time, which is great. Can you explain then the other side of caring for someone in a long-term care facility, in terms of the types of seniors that you see as a nurse practitioner?
There's a large variety. So when I in assisted living, some of my seniors they're just go-getters. They're out doing things, going on trips. I remember in one facility, they took them whitewater rafting.
You're kidding.
They loved it.
Oh my gosh. Did they realize how dangerous that is? Or could be?
They didn't care. They wanted to go. They had an experience. And so that's what I want to say. If they're willing to go and they're, to have that experience, they let them have that experience, and they loved it. I remember one year we had the Senior Olympics because it was Olympic time, and they had games down the hallway, like rolling the bowling ball down the hallway and wheelchair relays.
Oh my gosh.
And so that's what I want people to think of, is not just, people that can't do for themselves. I mean, you have that level, don't get me wrong, but you also have the level of people who are just thriving. My own grandmother moved to assisted living when she was about 101.
Wow.
And so for her, it was great because she had people she could talk to her own age with the same kind of lived experiences. And she didn't have to worry about keeping house and all that stuff. And for her, that she thrived there for her last couple years. So that worked out for her. Now, I've had residents that were unhappy about having to move to a facility. I had one particular lady in home care when I was an aide, and she said, if you put me in a nursing home, because she used to be a volunteer in a nursing home, I'm just going to die. Well, they didn't have a choice. She didn't have any family, and she had heart failure. Her dog had heart failure. Okay. They had heart failure together.
Oh my gosh.
So she refused to go to the hospital until we found a place for the dog to go, because the dog had to go to the veterinary hospital because they were both failing at the same time. So unfortunately, the dog died. They said she was going to have to go to a nursing home. 2 days later, she died in the hospital. She refused to go. So you have stories like that that happen, right? But it's not always that. So there's as a legal nurse consultant, I see probably the bad things that happen in the job. But then as a nurse practitioner, I can tell you the wonderful things that happen. We had a gentleman come in, and I had experience with this gentleman before in another facility. And he was very angry at that facility because he was, youngish. He was in his 50s, but he had a stroke and some other health complications, and he had to be in a nursing home because there's no one else to care for him. And he was a recovering alcoholic. So let's fast forward to a couple years later, and I meet up with him at another facility, and he's on hospice care because of heart issues. Well, he was having a lot of abdominal pain and things like that, and he was still a little angry, but not as bad. So I went ahead, did the CT scan and a workup, and then found out that because he had a previous history of prostate cancer that he never dealt with. He had metastasis to his bones, his liver, bladder, everywhere. And so when we got the workup, we didn't go any further because we thought he might have also had some metastasis to his brain because his behaviors were changed. We didn't bother to get the head CT. Once we found that, we're just like, there's no need. So we had to sit him down and we tell him, your cancer had advanced. And that basically his prognosis was very poor and he was going to die. So I had to have that conversation with him as a nurse practitioner, which is one of the hardest conversations to have.
I can
imagine. I remember sitting down with him and saying, Jerry, do you understand what I'm telling you? This is going to kill you, and you are going to die, and probably soon, within the next, at least, I would say 90 days, because of how advanced it was and the pain he was having. I said, and we're going to do everything to keep you comfortable. And when I said that and explained it to him, that's when he started to cry. But here's the great part. the staff at the hospice and the nursing home were able to contact his family. They got his estranged sister to come out and see him.
Mm.
When she sat with him, he wouldn't say anything. So she'd sit there for an hour and then she'd leave. And she said, well, I'm not going to come back because he doesn't even talk to me when I come. I said, well, hold on, let me talk to him.
Mm-hmm.
So I talked to him and I said, your sister says you don't even talk to her. So she's feeling like you don't really want her there. He says, I do want her there. I don't really want her to say anything. I just want her to sit with me. I just want to know that she's there. So I went back
Mm-hmm.
and explained that to her. He said, because he didn't know what to say because they had been estranged for so long.
Exactly.
And so when I explained that to her, she says, okay, all right, I can come back and I can do that. And the hospice got together and had a family reunion for him at a local
Mm.
park and brought all his family in. I get a little teary thinking
Wow.
about that. And so at the end of his life, he was able to make his amends to his entire family and die peacefully.
That's incredible. I love that story. It sounds like the hospice unit as well as the nursing
Mhm.
home really helped this person reconcile with his family before he passed. I think
Yes.
that is just wonderful that you're able to do that. Sometimes we don't hear some hospices going above and beyond, and I really admire the care that your hospice was providing for their patients. So thank you for that. Are there any other stories that come to mind?
Um, I want to give you some examples of some what I like to call train wreck stories.
Okay.
So the families will understand because there are times when things don't go as planned.
Mm-hmm.
So, for instance, I've got one. There's a lady moved into a nursing home, into the a dementia unit.
Mm-hmm.
Her family, her son and his girlfriend said, we're going to take her money. We sold her house. We're going to take that money, build another house, and build a wing for her to move in with us. Okay. So
Mm-hmm.
she's only going to be there for a few months so we can get this house built. Well, they took the money from her sold house. And instead of building a house for her, they built a house for themselves and bought themselves new cars and all this. And the staff knew it. So this woman
Mm-hmm.
was very bitter and angry because she thought she was going to be leaving. And they kept putting her off, putting her off, putting her off. And she was just complaining the whole time.
Mm-hmm.
Well, the daughter in law, right? Um, we believe had some sort of mental health issue because she would come in here raging at the staff about what they're not doing. And the staff had bent over backwards. The administrator had special meals prepared for this woman because she wouldn't eat anything that they had. I mean, they did everything they could to make her happy.
Mm-hmm.
And they were horrible people, horrible people.
Mm-hmm.
And so they ended up firing two of the physicians, including the medical director from her. We had a therapist come in and do family therapy with them. This never happens in a nursing home, but family therapy with them once a
Wow.
week. And then they finally took her off in a huff. And sad to say, we kind of banned the resident from our buildings because of how horrible the family was.
Mm-hmm.
And she was so disruptive to everyone. And she'd already fired our medical director. So, that kept her out of several buildings and no one would take her back. So
Mm-hmm.
fast forward to a few years later, and she tried to come back to the facility and they would not have her. I say that to say, I understand that families are going through a lot, taking care of someone in the facility. You want the very best, but this is how not to get what you want. And by the way, she was the first, and to my knowledge, the only resident that we've ever banned. And there's a lot more that went into that story. But I'm saying that because I think families need to understand that, yes, you want to advocate for your loved one, but make sure the person you send um, has common sense. They don't go above and beyond, or like really, kind of, there was just a lot of instances, but there was a lot of dysfunction in this family. And so sometimes that family drama and dysfunction does not get resolved. And when they move in, they bring all those dynamics to the facility.
Totally get it. I've worked in them as a speech pathologist, so I can definitely relate. That kind of surprises me that the family could fire the medical director. I've never heard of that before.
Yep. Basically, they refused to let the medical director see her and asked for the associate medical director from another practice, a doctor from another practice, to assume her care. That poor doctor did. Because I worked for the medical director. When they fired him, they essentially fired me. And I was like, okay.
Right.
And that medical director, associate medical director, was like, there's nothing we can do. I mean, the patient herself was physically fine. It was, a lot of it was the mental health stuff and the fact that they kept gaslighting her and telling her that they're going to take her home, and they never did. They were hoping that with her dementia, it would progress enough that she wouldn't know. But this is a woman that when she first came, would escape the unit because she was dressed really nicely, could talk very well, and they thought she was a staff member. People would let her off the dementia unit because they thought she worked there.
Oh my goodness.
So she wasn't that far gone.
No, she wasn't. Were they able to do anything about the legal part with the house or anything like that?
No, because we talked to the administrator at the time, and they were like, "Oh, it's hearsay, and we don't have any legal grounds, and blah 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 blah. She's in a safe environment." Staff was very upset about this, but I mean, what do you do? And she gave them permission to sell her house, and obviously she can't live on her own. So, and
Wow.
they were her power of attorney, so they had the right to do that. So that brings up another thing with power of attorney. Make sure that you have someone, if you're a senior and you're listening to this, make sure you have someone that you trust, right? You don't want to be in, I hate to put this way, in a Britney Spears situation. So you want to make sure you have someone that you trust to make the decisions for you. And it may not be your family member. In the case of the lady that I take care of, I actually called her oldest daughter because she told me, oh, my oldest daughter would do it. I called her oldest daughter. She's like, she's lying to you. I'm not her POA, because her oldest daughter didn't understand what that meant. She didn't want to hear about it. She had her own mental health issues going on. And obviously was not in the capacity to make sound decisions for her mother. So, and then, that's when I took over. And it's been a journey. I can say that it's been a journey with her.
I bet. It sounds really complicated.
Yeah. It's interesting. She'll fight with her family, and then they'll try to draw me into it, and then they'll get mad at me because I have to put a stop to whatever shenanigans they're up to. But like I said, it's been an interesting journey. It's good to see that other side of it. And there are things that do happen that aren't good. Cases of abuse and neglect I've seen in the facility. Had a case that was a while ago, so it's since settled, so I can kind of talk about a little bit of the case. And the resident was on the dementia unit, and the staff called and said they found abnormal bruising in her vaginal area and wanted me to do an exam. And I said, no, she needs to go to the emergency room. Don't change her clothes. Don't change her bedding. Send her to the ER. They said, well, we think she might have had some sort of discharge, so we want you to go check it out and see if it's semen. I said, I can't do that. So long story short, they didn't do what I told them. They called the medical director and kind of downplayed it. Um, so the state gets involved.
Of course.
They get in immediate jeopardy. The police eventually get called because about 24 hours later, after they collected their own samples and did what I told them not to do, and then told the husband who lived out of state and said, "Oh, well, we think she just tried to climb over the side rail." Meanwhile, I get a call at home from the state and said, "What happened?" And so I'm explaining to the state. This ends up going into a lawsuit when the family found out the whole story.
Mm-hmm.
And the woman dies. It goes into a lawsuit. And of course, it settles because if they went to trial, this would be devastating. Out of this whole thing, the administrator was let go. The director of nursing was transferred into a non-supervisory role. She was basically made a corporate trainer.
Mm.
And it was really their corporate staff that wanted to keep their names out of the paper.
You can't.
That was the whole thing. They wanted to cover it up. And I'm like, and I had talked to the lady from the state. She said, if they had just done what you said, they wouldn't have gotten immediate jeopardy. Everything probably would have been fine, but they didn't. And so it's when you cover things up,
Right.
that's an issue. So look at the staffing patterns. Are people getting turned when they're supposed to be getting turned?
Mm.
Are they soiled? I've come into places where I've seen the brown stains around them. That means they've been there for a while.
Mm-hmm.
So look at those types of things in the facility. There are wonderful facilities out there, and that's why I wanted to talk about the wonderful ones, so that when you see one that's not so great, you understand that all facilities are not the same.
You're right, they aren't. And it really depends like on the staff, the facility itself, and what other alternative programs that they have, like rehab programs or just recreational therapy.
Yes.
Expertise in the facility, because otherwise you're not really improving the person's quality of life if you're just having them either stay in the room or wander down the hall. So you've told us a little bit about what things to look for in a long-term care facility, what we call a SNF or a skilled nursing facility. And you've talked about being a caregiver in that situation for a church member. And you've talked about some of the good as well as the, I guess, inappropriate things that occur in a long-term care facility. So since you've started to bring in some of the legal issues, can you give us some idea of what may occur in a long-term care facility and what court suits have been settled, I guess?
Okay. Well, there's a variety of different things. One of the biggest things that the two biggest I could think of that seems to result in a lawsuit typically are pressure ulcers, sores in the bottom, because and sometimes some sores are inevitable, depends on the circumstance of the individual. I had a lady that had a type of connective tissue disease that caused sores.
Okay.
And we had her go to the wound center and all that, and it just never heals, right? That's something different. But then you have the pressure ulcer that is there because they're not getting turned, they're being neglected. Maybe they had a wound for some reason and they're not changing the dressing. In fact, I just read an article about a facility in, I think it was Detroit, and they found maggots in someone's womb. Yes.
You're
Yes.
kidding. Oh, how awful.
Yes. I happened to just check on that news article because then I think I covered some of that on my news show. And then the other one is falls.
Mm-hmm.
You know,
Right.
the individual falls for whatever reason. So there is a case where the person had never fallen or tried to get up from the commode before. The aide put her on a bedside commode, forgot to bring a towel, went to go get a towel. For whatever reason, the resident decided to get up and she fell and had a head injury. And so, because she had a brain bleed from the fall, she died like a week or so later.
Oh my gosh, how horrible.
So that's a wrongful death suit. So things like that, something that you may not have been able to predict, but you really shouldn't leave someone on the bedside commode alone. So it's those types of things like that that can happen. And so, you have to look at the individual circumstance. There are people that, fall for the first time. They've never had a fall and they just trip, and slip but you have to look at, was there a negligence? Were they wearing the proper footwear? Did they trip over something that was in the hallway, right?
Mm-hmm.
Did they go outside on an icy path? And so you need to look at the circumstances. And so maybe not all falls result in a lawsuit, and maybe not all falls are appropriate for a lawsuit.
Okay.
You have to look at that and stuff. So those are the two biggest that people will sue for that I see a lot of. So pressure ulcers and falls. And then there could be a variety of other things that can happen. And what you're looking at is, was the facility negligent? Was the providers that providing the care, were they negligent? Was it malpractice in some way? Did they miss something? Did they misdiagnose them? Did they fail to give the appropriate treatment? Those are the things that you look for. And so not every case is a legal case, right?
Mm-hmm.
Sometimes bad things just happen. I had a case where it was the other way. We had a lady that stopped eating,
Mm-hmm.
and she was having a lot of problems swallowing, and her neck was swelling, and then her stomach was swelling. And we had said to the family, we had said for months, because she had stopped eating, was not eating. I said, we need to send her to the hospital and get her checked out. We really do need to. And they would not let us send her.
You're kidding.
So no. So towards the end, it was so bad. She had this foul odor coming out of her mouth. They finally let us send her. She had cancer that had basically eaten away her esophagus.
Oh my gosh.
And the family is like, well, what can we do to treat her? Nothing. Keep her comfortable. That's all we can do now, because you wouldn't let us intervene when this first started months ago. They just, I don't know what it was. It was like they didn't want the expense. I didn't know. But they're like, no, we don't think she really needs to go to the hospital. No, we don't really want to have her worked up. No, we don't really want to have a CT scan. And when it came towards, there was nothing we could do. This woman, I'm sorry to say, died miserably.
Oh, it sounds so terribly. So terrible that the family just didn't intervene when they should have.
No. And it was horrible to watch. But then you have this case where something happens, and we had a family that they didn't even know the person had a wound. So they were sent to the hospital. The family insisted that they go to the hospital. This is one of my legal cases. And they didn't even know they had a wound because the facility didn't tell them.
Oh,
and
okay.
they told them, oh, the wound's not that, or I had a case where they told the wound's not that bad, and they get to the hospital and it's a stage 4 sacral ulcer down to the bone.
Whoa.
With osteomyelitis, when the bone is deteriorating. but it wasn't that bad in the nursing home, right? So those things happen, and unfortunately they happen. And that's why I say visit often, right?
Mm-hmm.
And ask questions.
That's a great point.
Yeah. I
You
mean,
have to ask about care. So I
yeah.
remember I was working with a senior who had, I guess, decubiti on his heels, and they put him in those fleece boots.
Yeah.
And then they were doing a lot of, I guess, electrical stim, the physical
Mhm.
therapist doing physical electrical stimulation so that they could close the wound faster. Um, I agree with you. I think that family needs to know, come in at unexpected times and just look around the facility and see what's happening with their loved one. I guess my other question is, how does a family member kind of walk in and then ask to have somebody turned? How, I mean, how can you prove that, I guess? Because I know that they have a charting system and they would have to
Mhm.
write down and initial it. So what if that wasn't happening? How would the family know?
Oftentimes the family wouldn't know, although they could request to see the medical record to see if they're adhering to their turning schedule. Um, a lot of times it may, if their residents able to tell them. I mean, I've had residents refuse to turn, and you have to document that they refuse to turn. We had a gentleman that didn't want to turn because he wanted to watch TV. So what the staff did, because he had such bad ulcers on his hips because he was bedbound, the staff put a mirror behind his bed so when he turned, he could still watch TV.
Oh, well, there you go. That
You
makes
know,
logical sense.
look for innovative things like that. We had a lady that had Huntington's, and we padded her walls by her bed. She was on a low bed with a mat. We put mats on the walls because she would flail her arms and hit her arms. And so she had all these bruises. So, in order for her to be able to still, slide off into the mat like she liked to do and flail as much as she needed to, we padded the walls around her bed. So, staff that think of innovative ways to keep the residents safe as opposed to, um, just letting stuff happen. And when you're there as a staff, as a family member, and they need to be turned or something like that, I hate to say it, but I'd say do it yourself, if you can safely.
Mm,
And I've done that. I would say be a part of the team, right? Work
okay.
with the facility. That always goes a lot better if you're part of the team and really informed. I mean, if mom
Mhm.
needs to be fed during lunch and you're there during lunch, offer to feed her, right? That
Exactly.
that brings you together with the staff. Sometimes I have people that say, well, that's what they're getting paid for. Yes, but that's your loved one. And
Mhm.
don't you want to be a part of taking care of them? That's a way of being included. A lot of times families feel very guilty that they had to put their loved one in the facility in the first place.
Right.
So this is a way for you to be included in those caretaking capacities. And a lot of times when staff see that you're willing to work with them and you're taking good care of your family member, it creates this bond and sense of camaraderie that they're
Mhm.
going to tell you things. They're going to do things for your loved one. They're just going to make them part of the family because they see that they have a loving family. Now, unfortunately, there are some residents that don't have family to come to see them,
Mhm.
and I find that most of the time, those are the residents that the staff kind of adopt.
Okay.
I've seen it where they adopt them and they know that they're not going to get a Christmas present because there's nobody to bring them a Christmas present. So the staff gets together and make sure that they have a Christmas present because they don't want them to be left out when they
That's,
have their big Christmas party. And the staff will be
mhm.
there to come and visit them when they're in the hospital and things like that because no one else will. So I've seen that happen. But then I've also seen other things. I'm going to say right now, we're in a staffing crisis in this country in nursing and nursing staff. I mean, I've never seen it this bad, to where in Indianapolis a few months ago, it was in our newspaper, all the hospitals in Indianapolis were on diversion because of staffing issues and COVID patients.
Wow.
That means they were sending patients all the way up to Muncie, which is about an hour and a half north. And then sometimes they were sending patients all the way up to Crown Point, which is probably about, I'm going to guess, I haven't been that way in a long time, 4 hours away.
Oh my goodness.
Because they didn't have beds. I was in a facility visiting someone, and I questioned about their medication, and they said, "Well, don't you know the hospital's running out of meds?" So they had to do some, instead of giving them two pills, they had to give them four because they were out of the 200 milligram tablets. So they had to give them 4 100 milligram tablets.
Oh my gosh.
Because they're running out of meds. So, and this is not just United States, because I've been covering this across the country. Places like China and Italy and Canada, they're all experiencing nursing shortages. So this is something we've not seen in a very long time, and it was coming, but COVID sped up the process. So we have nurses that are retirement age that just chose to retire. Why wait? Why put my family in jeopardy? Put myself in jeopardy? I'm going to go ahead and retire. We've had nurses that have just graduated, and some are leaving the profession already. They've been in the profession less than 2 years, and they're already burned out and leaving the profession completely.
Wow.
A lot of the faculty have retired, so you don't have a lot of faculty to train new nurses, and it takes a while to train nurses, and you want good nurses. So we're seeing this vacuum that's happening, and it's not just nurses that are burning out. It's physicians, respiratory therapists. And then I just talked a few weeks ago with a veterinarian who's also at the point of burnout, until he make significant changes to his practice. But there's a lot of pressure for veterinarians as well.
Oh my
to just
gosh.
see more and more and more patients for what, and I did not know that was happening with veterinarians until I happened to talk to one, because I don't have pets, I'm never home. I have plants. Those are my pets.
Okay, that sounds great. I can deal with plants.
Yeah.
Well, it's interesting that you mentioned like the nurse shortage, because there was an incident here in Colorado where I guess a nurse called the EMT and I guess the fire department or whomever. She was the only person in the facility for 50 patients.
Oh my.
And obviously you can't do a really good job for 50 people by yourself. So I think they had to divert some of the patients or the residents to different facilities because of the staffing shortage. And there was just no way that this nurse or caretaker was able to do all of that work by themselves. So I hear that it's going on. So are there really, I've heard some stories and I'd like to ask you about it. So since COVID, I've heard that I guess with patients that are disruptive, they've been medicating them. And I know that that is not what they should be doing. Is that something you've heard or read about?
I've heard a little bit about that. They were what the story I heard was that there are some questionable diagnoses added to people's charts. So what people don't know is that there's a Medicare rule that says, you have to have a reason for someone to be on an antipsychotic medication like Seroquel. Seroquel has sedative properties. So a lot of times when you have a dementia resident that won't sleep, you try to find something that helps them to sleep. And so it's on what's called the Beers list. And that's a list of medications that may be inappropriately prescribed to elderly persons unless they have I don't want to say legitimate, but a diagnosis that meets the criteria for needing that medication. So for instance, the lady that I take care of has a mental illness. She has to be on antipsychotic medication because trust me, you don't want her off her meds. Okay.
Okay.
But then what I've been seeing is that someone suddenly at 80 years old is being diagnosed with paranoid schizophrenia so that they can be on Seroquel or Geodon or something to manage those behaviors. And so the CMS, Centers for Medicare and Medicaid, they are cracking down on some of those diagnoses because you really should have evidence of having those conditions much earlier, like in your 20s and 30s. It's usually when people get diagnosed. There are rare cases of late schizophrenia, but it's very rare. And so all of a sudden, someone doesn't develop schizophrenia late in life. Now, they may have some other neurological condition that causes those hallucinations and the behaviors. And it may be appropriate in some cases to prescribe an antipsychotic. For instance, we had someone that had horrible hallucinations because of their dementia, and I think they ended up having like Lewy bodies.
Yes.
So because it was disruptive to their quality of life, we could document that they needed the medication to help them.
Okay.
Because there's nothing else we could do. Nothing else that worked. But I've seen a lot of people that were misdiagnosed or inappropriately diagnosed with psychiatric conditions so they could justify having the medications. And that's a phenomenon that's been documented in the media. And so those reports came out, I think, about 2 months ago. And so you'll see some of that happening. There was a case where a lawsuit that I was involved in, a nurse gave a resident Ativan, which was prescribed for her seizures. She gave it for anxiety because she was called like crazy.
Okay.
Okay. Yes, the medication may have helped. Maybe she did have anxiety, but it wasn't indicated for anxiety. The indication given was for seizures. So she gave the medication inappropriately because that's not what it was indicated for. Had she really wanted to have the indication changed, the nurse should have called the prescriber and said, can I give this also for anxiety? And that would have been okay. But she took it upon to do that. So there are instances where things like that may happen, and they did get cited for it, and it was found by the state on their survey, and they came in for something, and they found that, and they were cited for that, and they got a fine for that because the nurse did that. So those are some of those things that can happen. But yeah, right now what we're seeing is the inappropriate use of antipsychotics, and that's and I can say there's not a lot of good medications out there to manage those behaviors, right? There's some medications you can use, but a lot of times it's inadequate staffing and staff not trying other interventions before they go to medication. You have to document what's occurring so that you can have justification for that. So for example, when I was doing psychiatric nursing home rounds, they would list in the book that I would see for when they wanted me to see someone, oh, this person had this behavior, this behavior, this behavior. Okay. So when I go to the charting in the medical record, because the book, the log book for me is not part of the medical record,
Right.
there's nothing. And I said, there's no medical justification for me to adjust their medications because you guys didn't document anything. You have to document those behaviors in order for me to adjust the medications to help this person. Because according to your documentation, they're sleeping well, they're eating well, there's no behaviors. But you're putting in my book that they're having all these behaviors.
Right.
And so I had to, help train the staff. If it's important enough to put in the book for me to see, it better be important enough for you to document it.
Oh, yes, definitely. Another thing I know that they've changed over time is restraints.
Yes.
So you can't put a bed rail up because that's considered a restraint. You can't put a person in a jerry chair. That's a restraint.
And it depends.
Right. And you can't, I guess.
No more posies.
No, yes, I know. Posies. And then the hand restraints.
Mm-hmm.
And the medical restraints, the medication, definitely. Do you happen to see more of that happening because of COVID and the nursing shortages?
I've not seen a lot of restraints. A lot of facilities are restraint free.
Mm-hmm.
So we don't do things like when I was started as an aide, we would put the resident in the corner, in the chair, and then push the table up against the wall so that they basically wouldn't get out because we're trying to corral them for lunch. I mean, that's what we used to do. Keep them in the corner. They won't get up. They'll stay there so you get everybody down for lunch. We would put them up in their jerry chair and put the tray over their lap so they'll stay in the chair so we can get them ready for lunch. We can't do those things any longer.
You can't.
But what I've seen are some really good alternatives. We had a lady that basically wouldn't sit during meals. She would pace the whole time. She was up, and wherever she decided to sleep, she would just lay down on the floor. We care planned it. Wherever she fell asleep, we let her sleep there. We put a blanket over her. We watched her. But she wouldn't sit. So we just had a nurse walk with her and feed her from a plate as she walked, and she would eat a little bit, walk a little bit more, eat a little bit. So that, I mean, you just have to be creative. But that, I haven't seen a lot of restraints because they're just so taboo. I can't remember the last time I had anybody in a posy. And what I mean by posy is like a vest restraint where, for people that don't know, where, we had a lady, we used to do that. We used to put her in a posy vest and take the loops of the back of the vest, and we would put over the handlebars of her wheelchair because she would lean over the whole time, and that kind of forced her to sit up, and then she had a lap buddy. Well, she was double restrained. You can't do that stuff anymore.
Right.
For good or for bad. And so, those are some of the things that I have not seen a lot of restraints. Now, that may be in other facilities. I just not seen it here. I know Indiana, they've kind of really gone away from restraints. Unless you're on the medical unit, right? An ICU or something like that. Or a psychiatric unit. And then with a psychiatric unit, there's a lot of paperwork to even do a restraint or a seclusion. I mean, there's a lot of paperwork and a lot of documentation has to happen. Physician face to face. You have to check on them like every 15 minutes, loosen them like every 30. I mean, there's a lot that goes into it. So if you can avoid it, then that's always better. But I've not. Now, we can do a half rail, not full bed rails, but you can do like a half rail if they're using it for positioning.
Okay.
So those things you can do.
Okay. I know things have changed quite a bit since I worked as a speech pathologist in nursing homes, or chronic care hospitals. So I know the things I'm glad have moved in that direction where it's restraint free, because that really doesn't help the person.
No, I've seen some innovations where they're putting in like cameras
Okay.
and robots and things to remind them to not get out of bed, or they'll notify them. I mean, we still have the bed alarms, which
Mhm.
now are considered a restraint and going against patient dignity in some cases. We've got floor mat alarms. We still have the low high beds, those types of things. But it really has to be individualized. And that's what I want to point out. It has to be individualized to the person.
Okay.
So, for instance, the lady that we had, that she was in a low high bed because she would flail. We had it the mat so she can scoot out of the bed, and she would scoot right onto the mat. She wouldn't get hurt. We had the
Mhm.
mats on the walls so she wouldn't get hurt. This was for her dignity because she liked to move around. We had another gentleman who had developmental issues, and he was a little tiny thing, and he couldn't walk anymore because he had severe osteoporosis and scoliosis. So he would crawl. So we gave him knee pads and elbow pads, and for his therapy, we would take him out of his chair and put him on the behind the nurse's station where there's carpeting, and let him crawl around. So you had to, be innovative in what you did. And that was the best for him because he at least got around to do things, and he just loved shiny quarters and Coca-Cola. I just remember that about him. You know,
Okay.
shiny quarters
That's,
and Coca-Cola made his day. That's all he wanted.
and I'm sure he could find it near the nurse's desk. So,
Oh
um,
yeah, staff would bring him in quarters.
yeah, yeah.
He do he would have good behavior and would be rewarded with a quarter, which he would turn into Coca-Cola because we'd take it to the vending machine and let him have his Coke for the day.
Okay. I think that's reasonable.
Mhm.
So I assume that he didn't get his Coke if he was unruly.
Yes, he typically wouldn't get his Coke if he was unruly, but he generally wasn't. He when he it was funny. He would basically curse you out every day, and that was his norm. So that was expected. If he wasn't cursing at you, then we knew he was sick. And we're like, oh no, he's gotten sick again. Let's go check him out. I was like, because he would be very docile. He'd go, I love you. And I'm like, oh no, you're sick. We got to fix this. We would know when he was sick. But he was a very energetic person.
Mhm.
Yeah.
Well, I'm glad to hear that you and the staff came up with some innovative ideas of how to maintain a person's dignity, but yet give them, I guess, the space that they needed in order to thrive, like you were saying. I really appreciate all this information from all different points of view. Um, do you have any closing words for caregivers about either caregiving, seeing it from your perspective as a nurse practitioner or as a possible legal issue?
I would say the biggest thing is just be vigilant.
Okay.
Work with the staff as much as you can. Try not to make, I don't want to say an enemy of the staff, but you don't want to be antagonistic with the staff.
Mm.
There are certain times when you might have to, advocate and be more forceful. Something
Mhm.
happens. Um, but you want to make them a partner in the
Mhm.
care of your loved one. And ask questions. If you don't understand what's happening, ask questions. When
Great
I
point.
was helping my family member, we had the question about whether or not, if the time comes, would she want a feeding tube?
Right.
And her whole thing was, well, I don't want to starve. And I said, no, if it comes to the point where you're really not able to feed yourself and you are declining and it's getting towards the end, I said, typically you don't really want to eat. Your body starts to shut down, and
Mhm.
forcing feeding on you may actually cause things to deteriorate more. And I explained to her the whole thing. So making sure that they understand what their choices are and having them make an informed decision. So if you don't know, ask. Don't be afraid to ask questions. That's the most important thing. Have the staff on your side. Have them explain to you what this procedure is. And realize that in long-term care, everything doesn't mean what it would in a hospital. So you have to remember, in long-term care, that's their home, right?
Yes.
So you don't invade someone's home and force them to do things. You try to go along with you, but if the resident doesn't want to be turned, you can't force them to be turned. If the resident doesn't want to eat a meal, we can't force them to eat a meal. This is their home and they have rights. If they don't want visitors, they don't get visitors, right? So we have to let the resident, for as much as they're able, to have their own autonomy, and that's important. So instead of making it a adversarial relationship, try to be collaborative in your approach, and I think that will go a whole lot better. And then, if of course, obviously, if there's something wrong, you can certainly make a report. You can call the state. You can do those things. You have those remedies, but don't start there, right? Let's see if we can come together on an understanding. I'll give you one last quick story.
Okay, go right ahead. I love him.
We had a resident that we were having a lot of behaviors out of her. She did not speak English anymore. She, her language was Farsi. She had forgotten, because of her dementia, how to speak English. So every day at in the middle of the afternoon, they would have their snack time, and they would bring her a cup of coffee and a snack. So we had behaviors around that time every day. Family comes in to visit. And we're like, what is going on? Why does she act like this? Come to find out, the woman hated coffee, but she couldn't tell us. Family said every afternoon she would have a couple of cookies and tea. So we started making her tea in the afternoon and a couple of cookies. Behaviors stopped.
Wow.
But we needed the help from the family to understand what was happening, because she communicated by pointing at pictures to us, because we didn't understand the language, and she forgot how to speak in English. So it was really difficult. And then once we figured that out, her behavior stopped. So, it's those types of things. That's why I say, if you're collaborative, let us know if your loved one was a third shift worker and that's why they don't sleep at night. We'll change the care plan. Let them stay up all night and then feed them lunch instead of breakfast. Yeah.
Great point. I really appreciate your experience and just some of the stories that you've told, because I think they have a lot of impact. And I think that makes a big difference in terms of the quality of life for that person. So to understand and collaborate is much better, I would agree, than to come in and, be really disruptive and make things worse. So thank you so much for being on today. I'm sure our listeners will have a lot to think about when after this interview. So thank you so much, Tina. I really appreciate you being here. If anybody needs to get in touch with you, will be more than happy to share that information with them.
Great. Yes. Thank you.
Thank you so much.